covering 1. Kidney and ureter emergencies, 2. Bladder conditions and trauma, 3. Scrotal and perineal crises, 4. Penile surgical emergencies, and 5. High-yield clinical pearls. Let's get to it.
Section 1. Kidney and ureter emergencies, starting right at the top of the urinary tract.
So first up is pyelonephrosis, basically an obstructed, infected kidney. Whether this blockage is from a stone, a PUJ obstruction, or a tumor, your patient is staring down a fever, intense pain, and honestly impending sepsis. And here is the absolute crucial exam pearl for you. Antibiotics alone, they are strictly insufficient. They will fail. You have to urgently decompress that kidney, typically using a percutaneous nephrostomy or a double J stent, just like it's highlighted in the treatment protocols.
All right, moving just a bit lower, we hit ureteric colic. This is when a stone wedges itself right in the ureter. The patient gets slammed with this sudden, agonizing loin-to-groin pain. For diagnosis, your absolute gold standard is the non-contrast CT-KUB. Treatment-wise, you start with NSAIDs, fluids, and alpha blockers. But, and this is a big but, if that stone is causing an obstruction with sepsis, you immediately step up to a stent or nephrostomy. No waiting around.
Section 2. Bladder conditions and trauma, moving further down the urinary tract.
Now this is arguably the single most heavily tested scenario you'll face, acute urinary retention. It's that sudden, truly agonizing inability to pass urine. Now causes can range from strictures to clots, stones, even certain drugs or neurogenic issues. But the #1 most common culprit in elderly men? Benign prostatic hyperplasia or BPH. Now whatever you do, hold off on a PSA test during this acute phase. Your immediate go-to move is urgent urethral catheterization to drain that painfully distended bladder, then you can treat the underlying cause.
Okay, let's talk trauma. Managing a bladder rupture relies entirely on the anatomy, and you figure that out using a CT cystography. It's a pretty stark contrast, really. If it's an intraperitoneal rupture, you are going straight to surgical repair. But if it's an extraperitoneal rupture, well, you usually just need simple catheter drainage, unless it's a uniquely complicated case.
Sticking with trauma for a second, here is a massive, and I mean massive, exam pearl. If your patient can't void, and you spot blood at the urethral meatus, along with a high-riding prostate, boom, suspect a urethral injury immediately. Do not, under any circumstances, try a blind catheterization. You absolutely must perform a retrograde urethrogram first. If you urgently need drainage, you go for a suprapubic catheter instead.
Section 3. Scrotal and perineal crises. Let's see how the stakes get even higher as we move downward.
Okay, this right here is a true vascular emergency, testicular torsion. The spermatic cord literally twists on itself, completely strangulating the blood supply. The presentation? Sudden, severe pain and a high-riding testis that lies horizontally. Crucially, and examiners love this, the cremasteric reflex is totally absent. Listen, this is a clinical diagnosis. Do not waste precious time waiting for an ultrasound unless you are truly on the fence. The only mandate here is immediate surgical exploration and bilateral orchidopexy.
And if you're wondering why we rush them to the OR so fast, the data brilliantly spells it out. Look at these salvage rates. If you get them to surgery in under 6 hours, you save the testis over 90% of the time. But delay 6 to 12 hours? It's basically a coin flip, right around 50%. Wait 24 hours? The salvage rate plummets to less than 10%. In torsion, time is literally tissue.
Next up is Fournier gangrene. This is an incredibly aggressive necrotizing fasciitis of the perineum, and it rapidly advances to septic shock. It commonly strikes patients with diabetes or immunosuppression. The presentation is honestly unforgettable. Sweeping swelling, a foul odor, and palpable crepitus, that crackling feeling under the skin. Your treatment? Stabilize their ABCs, hammer them with broad-spectrum IV antibiotics, and rush them in for emergency radical debridement.
Section 4. Penile surgical emergencies. The final stop on our top-down anatomical tour.
First up in this section is priapism, which is a persistent, usually painful erection lasting over 4 hours. The key here is you have to rapidly differentiate between two specific types. Ischemic or low-flow priapism is the true medical emergency. That requires immediate cavernosal aspiration and a phenylephrine injection. On the flip side, non-ischemic or high-flow priapism is usually related to trauma and is thankfully far less urgent.
Moving on to paraphimosis. This happens when a retracted foreskin gets physically trapped and it acts like a tight band, causing the glands to swell dangerously. Left untreated, it leads straight to necrosis, so you must escalate management step by step. Step 1, attempt manual reduction. If that fails, step 2 is osmotic compression. Still trapped? Step 3 is performing an emergency dorsal slit to release that tight ring. And finally, step 4 would be an elective circumcision at a later date.
Our last penile emergency is a penile fracture. This is a complete rupture of the tunica albuginea. The history here is classic. The patient usually reports a loud cracking sound during intercourse, followed by an immediate loss of erection, and then the rapid onset of the famous eggplant deformity due to all that severe swelling. Treatment? Simple. It strictly mandates immediate surgical repair.
Section 5. High-yield clinical pearls. Let's lock in everything we've covered with some rapid-fire CPSP Viva questions.
Okay, here is a classic board scenario for you. You're faced with a patient presenting with an acute scrotum. Out of all the possibilities out there, what is the absolute most likely diagnosis you must act on?
The answer is always testicular torsion. Seriously, the fundamental rule to live by in urology is that every single acute scrotum is torsion until proven otherwise. Period. Never delay that surgical exploration.
All right, let's try another one. If you suspect that urethral injury, maybe because you spot that classic sign of blood at the meatus, what is the very first thing you must do before anything else?
You must perform a retrograde urethrogram first, and you must completely, totally avoid any blind catheterization. If you try it, you risk causing catastrophic, irreversible internal damage. If drainage is absolutely critical, a suprapubic catheter is your go-to.
Well, I'll leave you with this final provocative thought for your exams and your future clinical shifts.